Okay. A very good evening to one and all. Myself, Dr. Ketan Kulkarni from the Medical Services team from MK. On behalf of the division, I invite all of you to this very exciting topic. So it is infectious diseases and ophthalmology cross talks. And we have with us today one of the very reputed speakers, Dr. Dipankar Pal, and two other speakers who will be the faculty for and the speakers for today's webinar. So, Dr. Dipankar Pal is a MD with a DM in infectious diseases from CMC Vellore, which is one of the most reputed institutions in India. And currently, he is the assistant professor, Department of Infectious Diseases, School of Tropical Medicine, Kolkata. So, before we start we start the webinar, uh, I will first introduce to the distinguished panel, distinguished speaker. So, Dr. Dipankar Pal is Assistant Professor, Department of Infectious Diseases, School of Tropical Medicine, based in Kolkata. So, as previously I mentioned, he was the infectious disease consultant with a doctorate of medicine from CMC Vellore. So, he is skilled in diagnosing and treating wide range of infectious diseases, including HIV, infections in the bone marrow, solid organ transplants, cancer in cancer patients, in ICU settings, neurological infections. I will share again. Vivek, are the slides visible now?
Yes, sir. Yeah.
Yeah. So he's skilled in a lot of infections, including neural infections, leading multidisciplinary teams, implementing effective antimicrobial stewardship programs, and he's certified from the
Your sound is breaking, Dr. Kulkarni. Sir, your disc.
Yeah, sorry for the inconvenience. There is an internet problem.
Yeah, okay.
Maybe 1 minute. Yeah, sorry. Yeah. I'll stop my video so that you can hear. Yeah. So here I was introducing.
Sir, we'll start with the Dr. Dipankar Pal introduction.
Political is sleeping.
I think Dr. Kulkarni, can you make it a brief? Because we are running out of time already. I think my introduction is already over. Can you briefly introduce Dr. Shankho and Dr. Tirthankar? Dr. Shankho,
Yes, sir.
uh, can you listen Dr. Kulkarni's voice? No.
No, sir, not at this moment.
Yeah. Sorry, there are some technical issues at Dr. Kulkarni's end. So, followed with the Dr. Dipankar Pal introduction, I'll request Dr. Tirthankar Mukherjee to start his presentation. So,
Okay. Should I share my slides or it
yeah,
will
yeah,
be
yeah,
shared?
yeah, 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 yeah. You please share your slides.
Fine.
Dr. Yogesh, there will be problem because I got connected through mobile and my slides needs to be shown by changed by Dr. Ketan only. Sir, I'll be sharing your slides. No issue, sir. Okay, okay. Then let's start. Dr. Tirthankar, you please start. Yeah. Yeah.
1 minute, I have to share my slides. Is it visible?
Can you share my
आ गया.
slides? Can you share my slides? Because I have sent them now. I don't have the laptop with me now. Actually, I am on the
Yogesh,
tab.
can you share his slides or?
Okay.
You have only means my slides you can share. You are asking to me. The problem is from Dr. Kulkarni's end. That is the issue.
Okay, should I start or?
Like you can. Yeah. Can I share it from mobile also? No. No.
Tirthankar, Dr. Tirthankar, can you please um, stop
Share your
sharing?
slide.
Just a second. No. I shall share
Okay.
my. I'm just checking because Yogesh doesn't have. Okay.
Yeah,
Just
fine.
one second.
Yeah.
Just a second.
Yes, sir. So I'm there now.
Dr.
Yeah,
Kulkarni, you are back.
I'm back. I'm back. So I'll share Dr. Tirthankar's slides now.
Dr. Shankha Shubha.
Doctor, hello.
Hello.
Dr. Shankar, you have slides with you, sir.
Actually, I have with my laptop, but I have sent it now. Let me
I think
let me.
by the time Dr. Ketan,
Yes, sir.
do you have my slides?
Yes. I have got your slides.
Okay. And Dr. Tirthankar, you can share your slides.
Okay, 1 minute.
Then you let's do one thing. Dr. Ketan,
Yes, sir.
we are already well late. Let Dr. Tirthankar start his presentation. You
Yes.
just in between, you just make Dr. Shankar Shubra's PPT in your laptop ready.
Right.
Okay.
Right.
Then you will share. Dr. Shankar will present his slides after
Yeah.
Dr. Tirthankar, and
Yes.
later on you will share my slides also. Okay.
Yes. I'll
Dr.
coordinate. Sir. I'll coordinate.
Tirthankar, please start.
Am I my slides are visible?
Yes,
Yes,
very much.
visible. Please start.
Okay, thank you. So let's start. So this is a case presentation of CMV retinitis. It's a diagnostic challenge. So let's begin. Here, this is me. You can contact me through my details.
Okay,
Let's yeah.
let's start.
So a 30-year-old gentleman comes to the OPD with a history of 2 years HIV and presenting symptoms of breast infection. He is on irregular ART since years. So general examination, which there was multiple abscess all over his body, history of significant weight loss over months. Other systems are apparently normal. So wait a second. Let's come step by step. So what could it be? It is a bilateral painless illness of vision systems. What could be the most 40-year-old male? What could it be? Most commonly, it would be a refractive error or a cataract or a corneal symptom pathology. It can be glaucoma and many other retinal symptoms. So let's go by step to our retina, CMB retina. So this is the ocular examination. So what we have? Visual acuity. Visual acuity in both eyes are PL positive, perception of light positive, with the projection of rays inaccurate in both eyes. So could it be refractive error? Nah, not so. Could it be cataract? Might be if it's a mature cataract, or it could be a uveitic or complicated cataract. So next, see the cornea. What about the cornea? Cornea is cornea lead adnexa or all are known. So we can rule out the corneal pathology. Okay, fine. So let's see the AC depth. AC depth is normal. So with IOPs, both eyes, right eye 18, on the left eye 16 mmHg respectively. So we can rule out pathology of glaucoma. Okay, AC reactions, they are nil. So we can rule out uveitis. So comes the lens. Lens is IMSC NS1 to nucleus sclerosis 1 to 2 grade. So can it be causing a PL vision other than unless and until it has a posterior segment pathology? No. So there must be a posterior segment pathology behind this. So let's time for fundoscopy and examination. It can be vitreous pathology, can be retinal pathology. Let's see the fundoscope next. So this is the fundus examination. It shows of a right eye. Right eye shows retinitis. Retinitis could be shown with hemorrhages with vasculitis. Okay, there is exudative retinal detachment involving the posterior pole, which has been developed. Optic disblurring with suggestive of papillaritis also has been developed. An appearance resembling a pizza pie can be suggesting a retinal necrosis. So what can we rule out from there? There are signs of vasculitis along with hemorrhages. So we can rule out progressive uh, we can rule out POR, progressive retinal necrosis. Fine. So there are classical signs of CMB retinitis could be seen in this. Next slide. Next, with the other eye. Other eyes, there are similar features of left eye exudative RD, with an appearance resembling pizza pie, suggesting of retinal necrosis, can be seen around the macular region. With vitritis is minimal. So we can rule, since vitritis is minimal, we can rule out ARN, acute retinal necrosis. We can rule out as it there is maximum amount of vitritis in ARN. So moving on. This is the fundus diagram of both.
Dr. Tirthankar, then the patient has presented with bilateral eye involvement and both the fundi are showing like pizza pie appearance. Is it?
Yeah.
Okay. Okay.
Yeah.
Please.
Both sides showing a pizza pie appearance.
Okay.
This is the fundus diagram. We can see retinal detachment with significant amount of subretinal fluid in the right eye, with hemorrhages, retinal vasculitis, papillaritis. Similarly, in the left eye also, in the nasal region, we can see RD with subretinal fluid, with hemorrhages, papillaritis, vasculitis, and retinitis with retinal necrosis, involving the fovea and the macular region. So moving forward.
So it is not only retinitis. It is also means there is also that retinal detachment you are detecting, you are finding in both eyes.
Both eyes with subretinal fluid in adequate amount.
Okay, but vitreous was clear.
Vitreous is square. There is minimal signs.
So there is less vitreous infiltrate and cellularity, but both retinas are getting necrosed, and also there are presence of retinal detachment.
Retinal exudative.
Okay, fine. You can progress.
There is a much amount of exudative collection between the neurocentric retina and the RPEs. That leads to retinal exudative arc. This is the USG scan of both eyes. I can zoom it to show you that though there is retinal detachment, you can see the retinal detachment of the left eye. but there is significant minimal amount of vitritis in left eye. There are no spikes. This is a vitreous chamber. There is significant less amount of vitritis.
So
Similarly,
in spite of retinal detachment, vitreous cellularity is minimal.
yes, minimal. This
Okay.
this is a classical feature of CMV retinitis, differentiating it from acute retinal necrosis. Classical. Okay, fine. Let's move on. Both eye fundus imaging shows clinical signs of CMV retinitis. Okay, fine. These are the differentials. As I've told, differentiated acute retinal necrosis, progressive outer retinal necrosis, HIV retinopathy, toxoplasmosis. It can be necrotizing herpetic retinopathy and syphilitic retinitis.
So these are the differentials you initially thought.
Third. So now I come to confirmatory diagnosis by investigations. So a provisional diagnosis of CMV retinitis was made previously with the clinical signs with fundus photo and USG. A torch profile was sent which showed a CMV IgG antibody positive, which in a huge amount, say 202. CD4 count was severely decreased. It is 47 cells per
It is
microliter.
less than 50. CD4 count is less than 50.
Less than
And you have
50.
performed on vitreous tap also.
Yeah. Vitreous time, this is the confirmatory diagnosis. It gives a CMV PCR DNA positive.
Okay.
So initial management with
So you have diagnosed your case in an advanced PLHIV with less than 50 CD4, presenting with bilateral classical pizza pie appearance, showing retinal necrosis and retinal detachment. And on vitreous tapping, you have found CMV PCR
positive. Also, it talks to a torch report IgG CMV.
So your diagnosis is confirmed. Very good.
So now the part. So initially the induction dose started with tablet Valgan cyclobit orally 900 mg twice daily for 21 days, and followed by maintenance dose of 900 mg once daily. If conservative management also is done with topical antibiotics to prevent secondary infection, is like the prophylaxis to prevent secondary bacterial infection. Steroids were given to prevent immune recovery immunities, and with IOP lowering agents. As we are using steroid, there could be increasing IOP spikes. Sorry. So then the patient is referred to this OPD. Patient is being treated in infectious disease. After 1 week, visual acuity improved to both eyes, FC 2 feet, finger counting 2 feet. Unfortunately, a fundus photo could not be taken due to other systemic complications which had been developed during this week. And a baseline indirect ophthalmoscopy was done, which showed slightly reduced amount of subretinal fluid and retinitis. This we can compare the slides, but there is significant slight amount of decrease in subretinal fluid and a reduced amount of retinitis in both eyes. Thank you.
Okay, you have nicely diagnosed and managed from your side. So I think then Dr. Shankho Shubro can take over the session and start his presentation, enlightening the more detail on diagnosis of CMV retinitis in clinical scenarios, what you people from ophthalmology come across not very often, but still in the ART era, post-ART era also, we are finding cases, not very often, but we are finding cases of CMV retinitis that Dr. Shankho Shubro will enlighten us in details on the diagnosis. What are the newer diagnostic methods and fundus photography and follow-ups.
Yeah. So we have, sir, Mr. Satya Narayan
Yes, sir.
will flash the slides. His slides are already flashed, sir.
Okay.
Dr. Sanka, you can start, sir.
Okay, next slide. Hello, good evening, everyone. I am Sanka Subra Choudhury. I want to highlight on the diagnosis of the CMV retinitis. So, next slide. Next slide. Uh, the CMV retinitis is a herpetic virus that is a double-stranded DNA virus. It has a nuclear capsid of 105 nanometer diameter and 162 capsomers. We all know that. And next slide. It is usually transmitted most successfully, most common opportunity for infection causing eye disease, but it is the second most common opportunistic infection in immunocompromised individual after tuberculosis. Actually, tuberculosis doesn't cause so much of ocular infections like a CMV does, and the transmission may occur in utero, perinatally, or postnatally. And once infected, actually it stays in the human body for a lifetime. And for the immunocompromised person, when the CD4 T-plus count comes down to considerable below level, like less than 50 microliter, then only it manifests its virulence. Next slide. The perinatal infection is acquired mainly through the infected genital secretion of breast milk, and we can only know that for an infant, 2 to 10% of infants are infected, and the perinatal infection is thought to be 10 times more common. Next slide. And not only in case of HIV, as we all colloquially say that HIV causes CMV retinitis, but any immunocompromised state like post-organ transplant, be it a hematopoietic cell transplant or a solid organ transplant, these CMV retinitis may occur. And but there is a difference between these stem cell transplant CMV retinitis with that of a HIV retinitis, because the HIV retinitis less, the number of injections or the number of treatment cycles are less than that of the organ transplant recipients, and the HIV induced CMV retinitis patients actually survive longer. But though the organ transplant patients actually require more of the doses, but they have a less common complications of eye diseases seen. Next slide.
Probably, Dr. Shankho, that is because of their used to get immunosuppressive for more prolonged period. But once you start
Yes, sir. Yes,
ART
sir.
in HIV patients, your immunity is slowly getting reconstituted. And at a point in time, at some point in time, the immunity is good enough to control the disease. So you can stop the maintenance
Yes.
therapy also. That is not the same in SOT and HSCT recipients.
Yes, sir. For a CMV retinitis, 57% of the patients are usually asymptomatic. Then the most common symptoms usually the patient presents are the flashes, floaters. Then the retinopathy begins, and the retinopathy actually begins in the peripheral retina with a mild granular or a vitritis. Mild vitritis then gradually progresses towards the posterior pole. And if it is not treated when the retinopathy is set in, further complications like retinal detachment can occur. Next slide. For the recent standardized uveitis nomenclature criteria, the CMV retinitis have actually 3 stages. The firstly, a wedge-shaped area of retinitis is found. As you can see in the picture, there is a superficial hemorrhage is the flame-shaped anodale with yellow exudates, but we have to carefully examine that these yellow exudates are not cotton wool spots. Now, these cotton wool spots can be found in HIV retinopathy, but these yellow spots are bigger, that is more than 720 micron, and these are characteristics for the CMV retinitis, unlike HIV retinopathy. And when these are actually causing the retinal thickening and the retinal edema. Next slide. Then this actually progresses where the posterior pole, all the vessels involved, the retinitis sets in, the periphleboitis sets in, and this is known as the hemorrhagic retinitis state. Next slide. And when we visualize the posterior pole, a mild vitritis with granular appearance is seen. And this next slide. And after that, all the four quadrants are involved, and these then the retina actually looks like a pizza pie, which is actually shown in the picture. We're comparing the pizza pie to the retina, and this pizza pie or the ketchup cheese retinopathy is when you are present, usually presents, and it is the absolutely pathognomonic for a CMV retinitis. And when the pizza pie sets in, there is, you can treat the disease, or you can CD4 count can increase, but this is indicative of the already the retina has necrosed, and the visual recovery from this stage is very poor. Next slide.
It is a progressive and sight-threatening disease. And I
Yes, sir.
think hemorrhage, it is commoner when the larger vessels probably is involved, I think.
Sir. Actually, the first and the second branches, when are involved, there is a posterior pole, then the retinal necrosis starts. The next slide I am going to talk about that. And then once the necrosis starting, it is very difficult to regain the vision.
And more superficial vessels and smaller vessels, if involved, probably that can give rise to more granular pattern, I think.
Yes, sir. Actually, the superficial retina is more involved, the inner retina is more involved than the outer retina. And the inner retina actually gets gradually hypoplastic with time due to necrosis and atrophy. And the outer retina is usually spared. Only the sometimes a little amount of subretinal fluid may get collected, but usually that resolves with treatment.
Okay, excellent. Because nowadays you people are getting less number of cases in CMV retinitis in HIV. So this clinical presentation and visual impression is very important, because if you do some vitreous tapping and for CMV PCR and for confirmation, that will take some time, and you cannot wait till the results come,
No,
because the
sir.
disease is very fast progressing, and it can give rise to permanent visual loss, and the visual prognosis will be gloomy. That's why the visual impression, when you people are seeing not only the direct and also indirect ophthalmoscopy, also the peripheral retina also you need to see. And the all should be, means that ophthalmologist, first of all, the patient may go to your side also initially to show the to consult for dimness of vision. So in that time, this finding is very important, especially for the fellows and residents also. If they fail to recognize, then it will be very difficult for the patient to regain his vision completely. But it is a treatable condition. Okay, you can proceed.
Next slide. Actually, the categorize the retinal involvement. It has the CMV retinitis is divided into 3 zones depending on the prognostic factors. The zone 1 is temporal to 1500 micron from the central of the optic disc. The zone 2 is from the margins of the zone 1 to up to 3000 microns, that is up to the equator of the retina. And zone 3 is beyond the zone 3 beyond the zone 2. Next slide. Actually, the zone 1 is very important, because once this zone 1 is involved, there is very significant visual impairment, and it is very not only challenging for the because more injections are needed, more induction phase has to be prolonged. There is higher complications rate associated with it when the zone 1 is involved. Next slide. These are the differential diagnoses. Actually, Dr. Tirthankar has said very well from the
But
same how to differentiate.
can you please tell the prominent differentiating points, not in details, just the
Okay.
prominent
The main,
differentiating
so
points
the
for
first,
each of the differentials.
the first is a CMV retinitis. We have to differentiate from a progressive outer retinal necrosis and then acute retinal necrosis. Now, CMV retinitis first, if we go from inner to outer, if we can see that the CMV retinitis has no to mild vitritis. While in cases of progressive outer retinal necrosis or an ARN, the vitritis is severe vitritis. Even it causes an anterior chamber inflammation also.
So the
Then we come,
vitreous will be hazy.
yes, sir. Obviously, the vitritis is
That
very hazy.
Dr. Tirthankar also told that in his
Hmm.
case also, he
Hmm.
not found enough vitreous inflammation, but there is
Hmm.
devastating retinal necrosis and retinal
Hmm.
detachment. That's
Hmm.
why his initial impression came.
Hmm. So then from the vitreous, if we go to the superficial retina. Now the superficial retina actually is more involved in cases of progressive outer retinal necrosis and for CNV retinitis. Because there is a necrotic retina, there is pigmentary changes, yellowish changes, but the yellowish and white changes in cases of ARN or in case of progressive retinal necrosis are very smaller in size compared with CNV retinitis, where the yellow lesions we see are very, the dimensions is a very large than a PORN or an ARN. And then in cases of acute retinal necrosis, it happens in cases of an immunocompetent persons. When in cases of CMV retinitis or progressive outer retinal necrosis, it happens in cases of immunocompromised individuals.
So the
And for
host
the,
factor, by considering the host factor, you can rule out acute retinal
yes,
necrosis.
sir. If it is an immunocompetent person, and you are saying a immunocompetent person with a severe vitritis both in anterior chamber and the posterior chamber with yellowish lesions and hemorrhages is diagnostic for acute retinal necrosis.
Okay. Then syphilitic retinitis.
Okay, then sir, syphilitic retinitis, usually for syphilitic retinitis, we first have to check the systemic involvement is there or not. And then for syphilitic retinitis, we can see there is yellow to orange lesions, and this involves from the mid of the periphery up to the equator. And there are numerous round yellow backward lesions which is present in the mid periphery of the lesions. Whereas in cases of tubercular retinitis, in early stages, there is there is vitritis, there is peripheриtis, and along with this yellow-white lesions, the yellow-white lesions are scattered throughout the retina, and with the time progresses, there are pigmentary changes around these white lesions. And for a toxoplasmosis usually comes with a retinochoroiditis or a chorioretinitis plus, followed by a vitritis, and there are multiple spots which are mother spots and daughter spots we can see. And for sometimes in a toxoplasma, there is also macular star can be found.
Okay. Okay.
So then the next slide. For a diagnostic of CMV retinitis, as it is previously told,
History, first is a host
history,
factor with low CD4
host
count,
factor, then the
along with
clinical
history and
evaluation is
clinical
diagnostic.
presentation.
Is a diagnostic for CMV retinitis.
Okay. Move on to the next slide.
Next slide. Now, for an ophthalmologist, we are in the OCT era. We actually do OCT for everything. For a typical acute retinal necrosis, as I have told you, that there is significant thinning of the inner retina with an hyperreflective descent and the destruction of all layers. For an atypical retina, the destruction all is seen, but the thickening in the inner retina you cannot see much as cases of a typical presentation. And in the healing stage, both the both the inner and the outer retinal layers are disrupted, and the retinal edema subsides. Next slide. Then upon the diagnosis, for the age-old method, as it is transmitted through bloody fluids, we can do serology through IgG,
We can
IgM.
we can restrict our discussion to immunocompromised patient only, because today's topic is only immunocompromised
Okay, sir.
patient.
For a immunocompromised patient, for serology IgG, IgM, usually IgG is present, but these only support a diagnostic. We cannot make a therapeutic decision making, and even for a immunocompetent patients, these can be positive. But actually, in today's age, this doesn't hold any value for a diagnosis of CMV retinitis. Next slide. The polymerase chain reaction is the most important thing. For polymerase, we actually tap aqueous humor and the vitreous humor, and we can go for a real time. And the multiplex, actually multiplex is for screening. We actually go for an PCR. Next slide. And here is a photo. You can see the 0.1 to 0.025 ml of aqueous can be directly tapped from the aqueous humor through syringe. And for a vitreous, we have to go inside the retina. We have to make the cutter on. And for the 1 ml or 2 ml syringe, we have to connect it with the aspiration tube of the cutter. And after we have make the cutter on with the infusion on, 1 to 3 ml of the vitreous fluid is taken into O vials or Effendorf vials, and then it is sent for the PCR. Next slide.
Is there any temperature recommendation how to send to the lab, or preservation if there is some delay? You are doing it in your OT. If there is some delay,
actually,
is there any current recommendation how fast it should reach the lab?
So actually, we try to make, actually we don't have PCR, so we have to send the PCR for a public private hospitals like Sankar.
Okay, that is okay, but is there any recommendation for how fast? I think that should be sent as soon as possible.
So
yes,
within
sir. 2 hours.
Whenever we collect it, we have to send it as soon as possible. If there have been instances that we cannot send the patient on the same day, as we know, then we keep the vials in the refrigerator and try to make the patient send on the next day. But it is said that the yield for the PCR actually comes down with time. So the earliest we can send and make the PCR, the better is the yield for the virus.
So in the smaller towns and cities, in any center, ophthalmologist, if performs aqueous or vitreous tap, if he or she has no PCR lab access rapidly, then he or she can keep it in 2 to 8 degrees centigrade in refrigerator and send it
store it in the refrigerator
on the next day. Okay, that's fine. Can you move on to the next slide?
The next type of diagnosis, the direct detections. For direct detections, as we all know, either by histopathology of the eye or by histopathology for the diagnosis of the CMV inclusion antibodies or the presence of CMV antigens. Now the CMV65 antigenemia test is not that much done nowadays. Next slide. For a virus isolation, conventional cell culture, obviously any cell culture pathology is the gold standard for diagnosis for any diseases. And then we can go for the DFF test, and which can provide results within, I think it will be 16 to 48 hours also. Serology I have already said.
But the problem with virus culture, I think from what you have shown in your slide, it is around 4 weeks. For virus culture, yes, it hardly helps. It can hardly help you in your clinical decision making and treatment.
Hardly helps because it delays the management.
So it is very difficult in clinical scenario.
Hardly helps because
So mainly in the centers where PCR is not available readily, you need to rely upon your clinical judgment and the host factor, clinical presentation, your clinical judgment, and you can send samples or tap or send samples, but you cannot delay your initiation of treatment.
No, sir.
You should refer the patient first to the treating physician. So by giving your impression to them, that possibly the CMV retinitis, chance of CMV retinitis is high in this patient, and empirically they can start if the means it's presumed CMV retinitis, I think. Okay, serology, I think it hardly helps in getting the diagnosis
I'll tell
done.
it is
I think,
for the direct antigen fluorescence foci, direct antigen fluorescence foci test, it also is not done because it also takes around 1 to 2 days. Next slide. This is the direct antigen fluorescence foci test for CMV. The yellow actually the CMV fluorescence foci. Next slide. Next slide.
okay.
And then for the follow-up, we have to mainly depend on the blood counts, like the absolute neutrophil count and the platelet count and the hemoglobin.
Focus on ophthalmological follow-up first. Focus on ophthalmological
Yes, sir. For
follow-up, please.
ophthalmological follow-up, we have to make a dilated eye exams. Initially, we have to see the patients every week. Then 2 weeks after the induction therapy. Then monthly after one, and then when it is resolved, it is cured. Still, we have to see the patient 6 months to 1 year lifelong. And every time we have to document the fundus photographs. OCT usually we do nowadays, but it's not essential. And obviously, every time we have to send the patient to the HIV clinic and make the CD4 count test. The next slide.
It is extremely important because once you have diagnosed and treated the CMV retinitis, you should keep your patient on lifelong surveillance.
Yes, sir.
Because
So,
there are
the
reports
induction
of
phase 1
relapse.
weekly, then 2 weekly up to 1.
Because there are reports of relapse
Yes, sir.
with CMV retinitis, that also in the opposite eye also, the previously normal eye can also get involved during the relapse. That will make the patient visually handicapped a bit. Okay, you can move on to the next slide.
And for the surgery, for a conventional surgery, only is needed for when there is a retinal detachments. And surgery, why we also means that intravitreal, intraocular ganglioside devices can be implanted for the treatment. Usually, these devices can last up to 6 to 8 months, and it does not have any protection for the fellow eye. Next slide. And then with the advent of the heart therapy, the most serious complications or the side effects of, we can say, the heart therapy is the immune recovery uveitis. Next slide. These immune recovery uveitis can also be found from the immunocompetent patients also. They usually patients with anterior uveitis and corneal endothelitis. Next slide. Now, there can be an acute CMV anterior uveitis, a chronic one, a recurrent or a chronic iridocyclitis, and a corneal endothelitis. Next slide.
So almost every part of the
eye can be
anterior chamber and everything,
from cornea
uveitis
to
tissue
ocular,
may get
anything
involved.
can affect. Next slide. So the acute CMV uveitis actually affects the Asian men from 30 to 50, and for the chronic ones, it is for the 50 to 70 years. The most important thing is the mild ocular injection with mild to moderate anterior chamber activity with diffuse, fine, stellate, and uniformly distributed keratic precipitates. I will elaborately say about the keratic precipitates later on. Usually, the IOP is elevated, but sometimes it can be borderline high. So the management for IOP and glaucoma is very crucial. The usually patient presents with ocular discomfort and blurry vision, and for a chronic anterior uveitis, there will be patchy iris, diffuse stromal moth-eaten atrophy can be seen.
Dr. Shanko, I think we are running out of time. Can you squeeze and discuss the important slides, rest of your slides? You can pick up the important ones and discuss.
Okay, sir. So next slide. This is, you can see about the both corneal endothelitis and anterior uveitis showing corneal edema with high elevated IOP. It's look like a bullous keratopathy appearance of the cornea. Next slide. For a keratic precipitous, I have told for acute ones that is white to gray capes. For a Asian chronic ones, it is white to gray capes, and for a brown ones, it is a brown capes. Next slide.
Okay.
This is the keratic precipitous, as you know, brown keratic between the lower half of the cornea. This is for the Asian populations. Next slide. Also, we can use the biomarkers to distinguish immune reactive uveitis from active CMVR, elevated IL-12 and reduced IL-6, and absence of treatment with CMV causes may suggest an IRU. We can also see the inflammatory mediators and the HLA associations. Next slide. The complications are usually cataract, the cornea, glaucoma, and ERM. Next slide. After we have prompt diagnosis for the CMV acute endothelitis, antiviral treatment should be initiated and anti-glaucoma should be properly taken care of. For the permanent corneal damage cannot be occur. Next slide. Using ganciclovir topical because the ointment is readily available and cheap. Then we can go for an ganciclovir oral, and if not, the best obviously is the valganciclovir oral treatment. Next slide. For an, if there is a macular edema, we can observe or give an intravitreal corticosteroids or anti-VEGF. Next slide. But in cases where there is a ganciclovir or valganciclovir therapy leads to severe side effects, letermovir is a suitable alternative, and it is already been FDA approved. For a CMV immunoglobulin mediated treatments, the work is still going on, and obviously it needs further research. Next slide. Surgery is indicated when there is a traction, CRM, or cataract at PVR. Next slide. These are follow-up patients. As we can see, there is a superficial hemorrhagic retinitis, and there is a superficial retinal edema. With time, the hemorrhage dissolves, the edema resolves, but the retinal necrosis remains. So there is in the follow-up OCT, the second and third OCT, you can see the macular atrophy of the retina has been occurred with formation of macular pseudohole. Next slide. These are my references. Next slide. Thank you.
Okay, from your discussion, Dr. Shankho, so 2-3 things, do you want to summarize?
So first, whenever patients with a low CD4 count presents with a dimness of vision, floaters or flashes, we have to check for the anterior chamber very well, there is uveitis or not. Check for the pupillary reaction, dilate the patients, and from the disc to periphery, we have to carefully observe the patients for any findings. Not only I am telling about a CMV retinitis, but also cases of HIV retinopathy or any organ transplant recipients, which also may show anipic retinopathy. We have to see the superficial retina, if there are hemorrhages, exudates are present or not, retinal atrophy is present or not.
So checking
Nowadays,
retina by dilated fundoscopy and indirect ophthalmoscopy is mandatory in any immunocompromised patient. Any immunocompromised patient.
And sir,
Okay, and also a post-treatment also the follow-up should be continued.
Yes, and sir, the main point we all definitely miss for the checking of the intraocular pressures. We actually go and check the anterior chamber and the retina, but definitely every time we have to go for a non-contact. We cannot make a contact tonometry for these patients. We have to go for a non-contact tonometry to check the IOP every time, because glaucoma has a devastating complications, and with the heart therapy, we all know that it has a IOP is actually increased, except for pseudophobia, the IOP increases in patients. So every time we have to check the IOP of the patients also.
Okay, excellent. We can now we can move on to my slides. Dr. Ketan, are you there?
There, I'll just share.
Okay.
So the
Can you
slides are
move to
shared,
the
sir.
next slide?
Yeah.
Just go to the next slide. Um, I will quickly do my presentation because we are already 8:30. So just start with a case. 38-year-old businessman from Kolkata presented with prolonged fever, weight loss, and occasional diarrhea. He was detected as HIV positive with a CD4 of 52. There was no visual symptoms initially. On clinical examination, there was mild anemia and other systems are also normal. Workup we have done, normocytic normochromic anemia, LFT creatinine were normal, stool parasites, urine, sputum, blood cultures, everything is negative. CT thorax abdomen for evaluation of fever in an advanced immunocompromised patient revealed mild hepatosplenomegaly without any focal lesions. Fundus photography, it was done in the baseline, showing in the left side and the right side the post treatment. So after seeing the baseline fundus photography, we have thought of that whether we are dealing with a case of early CMV retinitis because the patient was completely asymptomatic visually. So he had no visual symptoms, but still we have done this fundoscopy initially as the CD4 was low. Along with that, whenever we have found that fundoscopic appearance, we have done the colonoscopy and endoscopy to rule out the mucosal lesions as the patient has intermittent low-grade diarrhea also, whether there is CMV involvement of the gut, but we have found nothing. Mucosal biopsies were also normal. We have done. Serum crack as a part of the Y workup was negative. Toxo IgG IgM was negative. CMV IgG was positive and CMV PCR, though not recommended routinely in PL-HIV patients with this kind of retinal involvement, but we have done to document whether he is having high level of viremia. It is the 3-log copies, vitreous tap, patient did not give any consent. So with a presumed CMV retinitis, we have started him on Valgang cyclovir induction with 900 twice a day. He developed anemia and progressive neutropenia on day 6. His ANC absolute neutrophil count was 457. We have started him on GCSF for 3 days, completed successfully 2 weeks of Valgang cyclovir, and later on started on TAF, emtricitabine, and dolutegravir based regimen as ART. Maintenance Valgang cyclovir we have started as 900 milligram once a day with monthly fundus examination. So it is the importance of retina screening in asymptomatic but advanced PL-HIV is mandatory. That is the lesson we should learn whenever we are dealing with an immunocompromised patient. So CMV retinitis is the commonest serious ocular infection complications in AIDS. Up to 20% in all AIDS patients can present with. It is invariably progressive and leading to retinal necrosis and loss of vision ultimately. It occurs by mainly reactivation. 1982 in the year first reported in the pre-ART era. Up to 45 to 50% of cases in the pre-ART era with CD4 of less than 50 present with CMV retinitis. Commonest CMV reactivation end organ disease found in AIDS. Other CMV disease we know risk factors for end organ disease are CD4 less than 75. In many various studies we have found HIV RNA for more than 10,000 copies per ml. Routine CMV PCR not recommended that I was telling as pre-ART evaluation. Risk factors for CMV retinitis. It is a CMV viremia. Pre-ART studies, in the pre-ART era, studies show some association with CMV viremia, but in post-ART, multiple studies ruled out with the correlation of CMV viremia and CMV development of CMV retinitis. Retinal surveillance is the best approach that Dr. Shankwa and Dr. Tirthankar has already discussed in advanced HIV. Iatrogenic risk factors, sometimes HIV patients get steroids for PCP tubercular meningitis that may add to the immunosuppression further and reactivate CMV. Chemotherapy, radiotherapy for HIV-associated malignancy and blood transfusion also. Treatment, it is a potentially blinding disease, may be accompanied with other systemic areas like CMV colitis, CMV pneumonitis, maybe and CMV encephalitis also. Fellow eye may get involved sequentially. We should surveillance our fellow eye also, the patient's fellow eye also. Surveillance for years required. Fundus photography is a very useful tool. For the treatment, sight-threatening disease less than 1500 microns from fovea or lesions near the optic nerve head, we recommend systemic and intravitreal ganciclovir combination. But there is no RCT favoring this combination treatment. Induction agents and durations and doses already discussed. So I'm not going into details. Alternative agents are IV foscarnet and cidofovir. Valganciclovir nowadays it is commonly used if patient doesn't have associated CMV colitis, there is no absorption issues, you can get away with oral valganciclovir. It's an excellent oral bioavailability and it is 10 times more bioavailable than oral ganciclovir. It is easier to administer, no line-related infection, lesser cost, but it has equivalent bone marrow suppressive effect like ganciclovir. So there is a RCT done which between oral ganciclovir and IV ganciclovir induction. It was done between 1997 and 1999. 160 patients, multi-center, 42 sites. 80 patients received IV ganciclovir and 80 oral valganciclovir. It initially they have excluded the serious sight-threatening lesions. They were scared whether oral therapy will be sufficient to control sight-threatening disease or not. But later on, they have included. So the primary outcome was progression of retinitis in the first 4 weeks. From the graph in the above left, we can see that cumulative proportion without progression was equal between oral valganciclovir and intravenous ganciclovir. And the right lower graph, we can see the pharmacokinetic parameters. The lower graph was valganciclovir, oral valganciclovir, and the upper part is the IV ganciclovir. And the right upper part, the graph, it shows though the plasma concentration of IV ganciclovir and oral valganciclovir differs, but the area under the curve, the exposure of CMV in the retina with valganciclovir and IV ganciclovir was equal and comparable. And achievement of a satisfactory response to induction in first outcome. So the oral valganciclovir is non-inferior to IV ganciclovir. Next slide, please. Yes, IV ganciclovir and IV foscarnet. IV induction was previously widely used before the Valgan era. Foscarnet is preferred in ganciclovir and valganciclovir toxicity. Patient developing severe myelosuppression can be tried with foscarnet, but with ANC of less than 500, platelet count of less than 20,000. Ganciclovir and valganciclovir has mainly severe bone marrow toxicity, but the foscarnet has its own nephrotoxic potential and electrolyte disturbance also. Next slide. These are doses of IV foscarnet. I shall discuss the adverse reactions also only. The nephrotoxicity is seen up to 20%. Infusion-related decreased ionized calcium, dyselectrolytemia, genital ulcers, and fluid overload anemia. These are the common side effects of IV foscarnet. So monitoring should be robust with CBC, creatinine, electrolytes, with weekly, even with during the maintenance therapy also. Next. Here there is a head-to-head comparison between IV foscarnet and IV ganciclovir. There was 234 patients they have included in this RCT. This can be if the patients with ganciclovir arm, if they develop some bone marrow suppression, they can be changed over to foscarnet, and foscarnet arm, if there is nephrotoxicity, can be changed over to ganciclovir. But this trial was prematurely terminated because ganciclovir showing higher rates of mortality. in this study. The causes I will discuss in the next slide. But the median time to progression between ganciclovir and foscarnet for retinitis progression, it was similar. It was 56 days with ganciclovir and 59 days with foscarnet. But the mortality, it was higher in ganciclovir arm. Probably it is associated because it was done in 1991 and 92. That time we didn't have robust ART regimen, and ganciclovir group, we could not give zidovudin as the only licensed ART at that time. So zidovudin ganciclovir has combination. This combination has more myelotoxicity. That's why probably the arm with ganciclovir, IV ganciclovir has received less ART or less number of zidovudin cases. The off-label use of diadenosine has just started at that time, and probably that may be the reason. Another important point is foscarnet has anti-HIV efficacy also. So zidovudin plus foscarnet have synergistic anti-HIV effect in that time. Next slide. Cidofovir is the last resort, drug of last resort. The nucleoside monophosphate is given as weekly basis, 5 milligram per kg weekly for 2 weeks, followed by alternate weeks. Saline hydration and high dose probenecid should be given for renal protection. It cannot be given with high creatinine, low EGFR, and higher urinary protein. Cidofovir is another important point, is associated with immune recovery uveitis. Avoid in those cases with high risk for IRE. Toxicity that I discussed, serious irreversible nephrotoxicity. It can cause Fanconi-like syndrome and renal failure like tenofovir TDF, neutropenia, peripheral neuropathy, anterior uveitis, and low intraocular pressures are other potential side effects. I will not go into details. The next, can you move on to the next slide? This RCT, due to lack of time, will skip. Then is a much interest is intravitreal therapy. Systemic therapy, the principle of intravitreal therapy, systemic therapy takes few days or doses to achieve steady state intraocular concentration that we know. Intravitreal drug quickly achieves very high concentration and controls the viral replication in situ. Systemic therapy should be combined with intravitreals whenever the visual prognosis is gloomy. What intravitreal cannot achieve, disease development in the opposite eye, the fellow eye is at risk, and other extraocular CMV like CMV colitis and CMV pneumonitis, encephalitis, this cannot be taken care by the intravitreal therapy. Next slide. Intravitreal ganciclovir, the dose, there is low dose and high dose regimen. It should be given in weekly for 2 to 3 weeks along with systemic therapy. It always should be combined to protect the fellow eye and other potential sites. One injection is sufficient if there is systemic treatment started within 24 hours of intravitreal injection. It shows good response. Maintenance therapy, weekly intravitreal plus oral valganciclovir should be given, and it can be stopped as soon as retinal opacity resolves. And only adverse effect with intravitreal therapy is direct retinal toxicity in higher doses. And with endophthalmitis, there are infective complications, vitreous hemorrhage, and retinal detachment. Next slide. Intravitreal foscarnet can also be used. I'm not going into the details for intravitreal foscarnet. Next slide, please. There is a interesting study, treatment of cytomegalovirus retinitis, the sustained release ganciclovir implant. It was done in 1997 in 18 cities of USA. 188 patients were randomized with implant delivering 1 microgram per hour, implant delivering 2 microgram, and IV ganciclovir. Active retinitis, patients with PLHIV with active retinitis with adult patient more than 18 years. Here we can see the CD4 count is less than 50 in the baseline characteristics. Can you go back to the previous slide? It was very less, around less than 50. Bilateral CMV retinitis in around 1/3 of the cases we have found, and duration of the HIV status around 4 to 5 years. Can you move on to the next slide? So the analysis, the right upper side Kaplan-Meier curve, it is showing that the intravenous ganciclovir performs poorly in comparison to intravitreal when intravitreal ganciclovir is used alone in controlling the CMV retinitis in the diseased eye. So in the left-sided table, we can see the intravenous ganciclovir versus the combined implant group, means that 1 microgram and 2 microgram. If we take into account both the implant groups, the risk ratio for retinitis progression is around 3 times, 2.83, around 3 times risk ratio for progression. And the median time of progression is also 221 days for 1 microgram and 191 days for 2 microgram, and 7 days much earlier with IV ganciclovir. So intravitreal ganciclovir does work, but it cannot protect the fellow eye and the other potential sites. Next slide, please. So substantial and clinically important benefit of treating CMV retinitis with ganciclovir intraocular implant is shown as compared to IV therapy. Even the important point, the ganciclovir resistant isolates also may respond to very high intraocular concentration with intravitreal injection or intraocular implant. The mean vitreous ganciclovir concentration achieved with IV therapy is much less, 0.8 to 0.9, in comparison to intravitreous injection or implant. It achieves around 4.1 milligram per ml. Is much higher. Even the resistant virus can respond. Next slide. Treatment of cytomegalovirus retinitis with an intraocular sustained release ganciclovir implant. It is showing much improvement. It's another small study. Can you move on to the next slide? So the treatment summary on intravitreal and intravenous is implant and intravitreal antivirals quickly achieve very high concentration, rapid antiviral activity, better visual prognosis, but it cannot control the disease development in the fellow eye and other extraocular tissue. Recommendation: selected vision-threatening retinitis and implants to be combined with systemic therapy. Potential role in ganciclovir-resistant virus also. Maintenance therapy to prevent relapse, but no RCT on maintenance therapy has yet been done. Relapse is common without maintenance before immune reconstitution with ART. Can you move on to the next slides? Then next one. Running short of time. Discontinuation is very important. When we can discontinue the maintenance therapy, we need to assure quiescent retinitis. At least more than 3 months of anti-CMV therapy patient must have received. CD4 more than 100 for more than 3 months at least, and patient is virally suppressed with combination ART. If CD4 drops below 100, reinitiate the maintenance therapy is the recommendation, but continue surveillance post discontinuation also. Relapse, not going into details, we're running out of time. Ophthalmological, next slide please. Ophthalmological monitoring, 2 weeks of induction therapy, you must monitor your eyes, then monthly during the maintenance therapy. Weekly monitoring for sight-threatening disease. Cidofovir, for those getting cidofovir, monitor intraocular pressure by tonometry. Post-treatment monitoring for IRU, at least 3 monthly or earlier. Next slide. Drug adverse effect monitoring, not going into details. Next. ART. When to start ART? This is our last topic. The immune recovery uveitis and immune recovery vitritis is an immune reaction to CMV antigens by augmentation of immune function causing vitritis, plus or minus cystoid macular edema, epiretinal membrane, and retinal neovascularization. Incidence of IRU is variable but have substantial morbidity. It varies from 0.83 per year to 0.109 per year. ART after 2 weeks of anti-CMV therapy is recommended. That is the take-home message I want to give. You should continue for at least 2 weeks of anti-CMV therapy before you start ART. But in selected resource-limited settings, you can start with careful monitoring. Next. There is no RCT on when to start ART after the anti-CMV therapy is over. But there is a few anecdotal reports and few observational studies which shows in the lower prevalence and severity of the immune recovery uveitis when ART started after 2 to 3 weeks versus immediately. So protective role of delaying ART until retinitis is controlled. But there is, as I have mentioned, there is no RCT found. Next slide. So, ganciclovir implant have some theoretical advantage of low immune recovery uveitis because it has very high intraocular concentration and sustained CMV suppression for at least 6 to 9 months. So, by that time, immune reconstitution occurs by ART. So, amount of CMV, amount of available CMV antigens and CMV replication in the eye is very important predictor for IRU, and it is less with ganciclovir implant. It has some potential or theoretical advantage, but there is no RCT. Predictors for IRU and IRV, it is the large areas of CMV retinitis, posterior pole involvement, treatment with IV cidofovir, and male gender. Next slide, please. Just principle of IRU, IRV treatment that Dr. Shankar has already discussed. ART to continue, we should not stop ART. Maintenance dose of anti-CMV therapy should also continue. No need for reinduction. There is the patient is worsening to reinduce with ganciclovir or valganciclovir is not the fact. Topical steroid initially, those with poor responders can give intraocular steroid injection and also systemic steroids. Next slide. There is few slides on drug resistance. Just skip few slides, please, Dr. Ketan.
Yeah.
Next one, later movie. It is there is much interest on later movie on CMV retinitis. It is a viral terminase complex inhibitor. It is active on UL97 and UL54 resistant variants. It is orally active but no myelosuppression. It is licensed in allo HSCT and also SOT CMV prophylaxis preemptive therapy. CMV retinitis in SOT, not in HIV. CMV retinitis in SOT patients, there are some reports successful use, though it is off-label. It is a we need to remember cytochrome 3A4 inhibitor is potential of later movie, and it has numerous drug interactions like NNRTIs, protease inhibitors, rifamycin, and tacrolimus also. With later movie, we need to practice caution while prescribing off-label later movie in HIV retinitis. Low barrier for resistance it has, active infection or active disease, very difficult, very high level of CMV viremia, later movie may develop quick resistance. Select. Resistant CMV or very high log copies, monotherapy is difficult. Next slide. Here is the report, use of letermovir as salvage therapy for drug-resistant cytomegalovirus retinitis in a tertiary care hospital in North Carolina. Letermovir for CMV between 2017 and 18, they have tried. They have given quite a high dose of 960 milligram daily. It is well tolerated. Total four patients, they have given letermovir for ganciclovir-resistant CMV retinitis after failing on ganciclovir, valganciclovir, and developing nephrotoxicity from foscarnet. 2 patients detected from aqueous humor PCR and 2 from fundus examination and CMV viremia. Next slide, please. And here we can see 4 patients, patient A, B, C, and D. The vertical lines is the therapy. We can first concentrate on the drugs like left side, valganciclovir, ganciclovir, foscarnet, maribavir, CMV, IgG, and letermovir. The horizontal lines signify systemic therapy, and the vertical lines are intravitreal therapy. So in patient A, if we can take, the patient received initially foscarnet as systemic therapy followed by foscarnet intravitreal therapy. But patient, due to some nephrotoxicity or some resistance, patient later on switched on to letermovir. And the below red line, horizontal line is letermovir exposure. But we can see that it cannot control the CMV viremia. The plasma CMV viremia anemia is persistent with later movie. Later on, this patient switch on to oral valganciclovir once the disease retinitis is controlled. In patient B, has received intravitreal foscarnet and ganciclovir followed by later movie, but here also it failed to suppress the viremia in that patient. In patient C, patient was initially given ganciclovir followed by, due to myelosuppression, changed to IV foscarnet, but later on patient was given, due to toxicity and drug resistance, patient given systemic letermovir followed by re-challenge of foscarnet. Here we can see the green horizontal line which can show the reinitiation of IV foscarnet. Here also, the CMV viremia cannot be controlled. But in the patient, this is the only patient where initial systemic ganciclovir and intravitreal foscarnet followed by systemic letermovir, it controlled the CMV viremia. So all four showed the clinical and virological control, but the virological suppression was not achieved, but CMV viral activities, the virological suppression means the retinal virological suppression that was achieved. Patient A, B, C, viremia uncontrolled that I have discussed. Intravitreal foscarnet is given in 3 patients. None had recurrent retinitis. 2 of the 3 patients are unsuppressed, have already selected UL56 resistance gene mutations for letermovir due to persistent high-level CMV viremia. So close monitoring is required whenever we are using letermovir, but we don't have any data on letermovir therapy on CMV retinitis in advanced PL-HIV who are intolerant to ganciclovir foscarnet and develop some resistance mutations. Next slide, please. It is the last slide, probably. So the last one is Maribavir. It is a UL97 gene product inhibitor. It is refractory and resistant CMV in SOT and HSCT. It is used. Clinical and virological responses seen, but it has poor ocular and CNS penetration and is not recommended in CMV retinitis control. I think that finishes the quick presentation. Due to constraint of time, I skipped at least 7 to 8 slides, but I think the main take-home message that I was able to give.
Yeah, thank you very much, sir. And thank you for your excellent clinical pearls and also guiding the attendees for this webinar. So can I take, there is one question. So can I take that question, sir?
Yes, yes, sure.
So there is a question that can non-HIV patient with previous retinitis donate cornea after death?
Can you the network is something problem. Can you tell?
Yeah,
can you repeat the question?
I'll repeat the question, sir. So can a non-HIV patient with previously treated CMV retinitis donate cornea after his death?
Okay, that is a very interesting question. I think Dr. Shankho Shubhro, can you please respond? Dr. Shankho?
Dr. Shankho, you're muted. You can unmute, sir. Yeah. Sir, again you are muted. Please unmute, sir.
Hello, can you hear me now?
Yes.
The
Anybody can donate cornea. Anybody can donate cornea, but we definitely will take the cornea, and after that we as well go for the blood tests. And for the blood test, we have to go for the CD4 count, and we have to check whether
that question, Dr. Shankho, question is probably you have not listened the question properly. The question is patient is non-HIV. So he develops CMV retinitis.
Hmm.
First of all, the non-HIV patient, if developing CMV retinitis, there must be some immunosuppression. Otherwise, it will not
Develop a
happen,
same
I think. Because CMV retinitis used to happen is extremely immunosuppressed patient. If it is non-HIV, then the patient probably, not all, probably that solid organ transplant patient or HSCT recipients, probably, if I am not wrong,
Yes, sir.
or any patients with massive means
It's a
CMI depletion,
tuberculosis or HTLV
CMI
or
depletion like
HTLV.
CMI depletion like chemotherapeutic agents or high dose steroids or other immunosuppressive, I think they can also get CMV retinitis. Once they completed the therapy, their means their CMV retinitis become quiescent, and the gang cycloid prophylaxis, probably maintenance therapy, probably also has stopped. So, I think that this kind of patients received SOT or HSCT, whether they will be fit to donate cornea later on, it is very difficult to comment. But if they
Sir,
at all they
sir,
want to donate the cornea,
sir, they
so
can
what
donate. Sir,
will be the recommendation?
sir, anyone can donate a cornea.
Okay.
Anybody. But the question is whether the ophthalmologist uses the cornea or not.
Oh, that they intend to they are intending to donate cornea so that it can be used only. No, otherwise why they will give?
But actually,
Do
if
you
someone
do
donate,
you
then
do you
we
accept
actually,
that cornea and put it
yes, sir.
in
We
another
accept every
patient,
cornea.
and
Yes, sir. We
you will
accept
use
every
it,
cornea.
you will transplant it to another healthy patients?
So we accept every cornea, but we go for blood checks, for CD4 count checks, for everything. And if there is adequate CD4 count present, then we can obviously use it.
Use it. I think if the we can, I don't know, I am also not sure. So whether we should give prophylactic therapy for in the recipient also, at least because the CMV retinitis, we are taking out the cornea and putting it into another healthy patients, whether he or she will require CMV prophylaxis at least for the initial period after the surgery. Are you
Actually,
aware?
sir, no, actually, if the CD4 count is very low, less than 250, then we do not use the cornea.
No, no, no. That is transplanted to a healthy patient. Na? Where is the CD4 is coming? CD4 is
No, no,
not
no,
in
no,
the
no.
picture.
No, sir. When we take the cornea from
Okay.
from the diseased man, we also collect
From the
blood from the
donor.
diseased man also.
Okay. 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 Okay.
And with the for diseased person blood, we go for the CD4 count checks.
Yes.
Okay.
And
Okay.
serology also.
Anything else, Dr. Ketan?
Yeah, so that was one question, sir.
Okay.
So so Dr. Deepankar, so how many patients approximately you see with CMV retinitis in HIV patients normally? Because this is to all attendees also.
Nowadays it became progressively rare, I think, but we still get, I cannot tell the exact numbers that monthly or yearly how many of cases we are coming across, but it do happen. It is less common because nowadays the government is endorsing test and treat for HIV. So whoever is getting tested positive for HIV, if there is no apparent why, the same day or maximum within 3 to 5 days, we are starting ART from government program also. That make the same retinitis rarer, I think. But it comes. It comes.
Right, sir. So just for because this is a cross specialty webinar, so just a take home message from you, sir, and the ophthalmologist also.
Dr. Shanko, can you summarize your messages? 2 to 3 summary points. Then I shall.
So first, any immunocompromised patient, especially for HIV patient, should go even if he's healthy or an immunocompromised patient who is having a SOT or an hematopoietic stem cell transplantation, should regularly go for an ophthalmological checkup, both are dilated and undilated yearly, even if he doesn't have any symptoms, because the most common presenting features is the asymptomatic presence. Because once the symptoms starts, then usually the patients present very late, and only we can just treat the some clinical pictures. Vision loss is hardly any treatable for them. So
So
any
you
patients
stress upon early diagnosis,
any
both symptomatic and
immunocompromised patient
asymptomatic patients,
should go for a diagnosis.
and the follow up, and follow up
Second
also
is
periodic follow ups.
periodic follow-up. So maintenance phase is 1 to 2 weekly, then monthly follow-up in the induction phase, and then yearly follow-up lifelong.
At
Even
least
if
life.
he's cured of the disease, still he has to go for a yearly follow-up.
From my perspective, from ID perspective regarding the treatment, the most important point, the severity and extent of involvement. If it is sight threatening, it is nearer the fovea, macula. So we need to give combined, if we have the facilities of intravitreal injections. Nowadays, the implants are rare, they stopped manufacturing. Intravitreal ganciclovir, there are centers who used to practice intravitreal injection. If severe disease, we should give intravitreal injections along with systemic ganciclovir initially. IV if patient has GI symptoms, and if not, then valganciclovir orally with ganciclovir injections intravitreally. And at least 2 to 3 weeks, based on the severity. If it is more severe, patient not responding very well, so we should give at least 3 weeks. Otherwise, we can get away even 2 weeks of therapy also. And one important point is count, monitoring of the blood counts, and if required, GCSF can be given, and periodic follow-up during the maintenance therapy. Most important is the drug toxicity, and follow-up with the ophthalmologist periodically in a monthly or 3 monthly basis. And one thing, it is getting treated means it is not the end of the story. He or she may relapse at any time during his or her disease course. He need to adhere to his ART regimen with periodic CD4 and viral load, yearly viral load counting and testing. And another thing is that that immune recovery, we need to very cautious. We need to differentiate between immune recovery VITs and CMV retinitis relapse, whether it is relapsing or whether it is immune IDs, CMV IDs, that we need to differentiate and give systemic and topical steroids in severe IRU. And if it is relapse, we need to give combined therapy also sometimes with intravitreal. Even in the resistant virus also, we need to give intravitreal therapy along with systemic therapy combination. Another, that later movie part, it need to be explored whether we can use off-label in few cases, that when we have ganciclovir and valganciclovir resistant, we cannot give a foscarnet due to nephrotoxicity. We have only options like cidofovir left, that is also full of toxicities like nephrotoxin and other toxicities, and it can induce the immune recovery. VIT is also cidofovir. So we can give intraocular ganciclovir injection in those resistant and intolerant cases to achieve high intravitreal concentration along with systemic later movie. But the problem is, before giving later movie to HIV, we don't have data. We don't have any report of CMV retinitis later movie therapy. So we need to be very cautious, and very high CMV viremia later movie is a caution we better avoid. But if we don't have any other option, we can try and with periodic follow-up of CMV viremia. That is the take-home message I want to give to the audience. Dr. Ketan, over to you.
Yes, sir. Yes, sir. There is one more question. Can we take, sir?
Yes, yes. Sure.
So the question is, if plasma viral load is not detectable, then presence of virus in the cornea, is it unlikely? So
No,
viral load
it is.
is undetectable.
Oh, I understood. Means plasma viral load is undetectable, but there is a virus in the cornea or aqueous or vitreous, probably. The CMV retinitis, probably it is in the retina or vitreous. So, one point I like to stress upon that it is CMV viremia is not required to develop CMV end organ disease in HIV patients. We often get CMV retinitis with suppressed CMV viremia. So it is not a necessary things. It is not a mandatory things that we. It is not in the diagnostic criteria. Also, we must get CMV viremia in the blood in HIV patients and CMV in the vitreous or aqueous humor. It is not like that. CMV can localize itself in the aqueous or vitreous and retina, cause damage. Even in the absence, it may be present in the blood. It may not be present. So it is not at all mandatory in the diagnostic criteria also that CMV viremia and in the blood and the CMV retinitis in the ophthalmological examination, we cannot correlate that the patient is having CMV viremia and suggestive retinal involvement. So it is due to CMV. If we want to pinpoint, if we want to confirm the diagnosis, we need to tap the vitreous and show CMV virus in the vitreous PCR. Retinal tissue if possible. That is not possible. Usually vitreous tumor, if we can take that, that is the confinement. It is not CMV viremia in the blood.
Great, sir. So thank you. So I think now there are no further questions I could see. I think Yogesh from RX list, please confirm if there are any more questions. Yeah, okay. Okay, sir. So Dr. Dipankar, sir, can we close now? Is it okay?
Yes, sure.
Yeah. So I'll just give a vote of thanks. On behalf of Infectious Pharmaceuticals, I thank all the faculty today for sharing their valuable experiences in the management of CMV retinitis. I also wish to thank Dr. Dipankar Pal sir for your excellent clinical pulse and advice to all the attendees who are attending this webinar today. So thank you very much, sir. And on behalf of MQ Pharmaceuticals, I thank you all and wishing you a great evening ahead. Thank you so much.
Okay, thank you all.
Thank you.